I'm Dr. Chris Turnbull. I'm a pain specialist in Wellington, and I'm here with Dr. Trina Keller, who's a neurogastroenterologist based in Brisbane. So, Dr. Keller, thanks for coming along and listening to your talk, which was fantastic. Can you tell people who weren't at your talk what's a neurogastroenterologist and how can pain specialists work with you?
Yeah, good question. Thank you, Chris. So neurogastroenterology is actually a subspecialty of gastro. There aren't very many of us, so people don't necessarily know what it is. In gastroenterology, you can specialise in liver, IBD or endoscopy, which people are more familiar with. But the fourth subspecialty is neurogastro. So we specialise in disorders of gut-brain interaction, which were previously called functional gut disorders, and in motility disorders, things like gastroparesis, achalasia. In terms of how we can work together, a lot of patients with disorders of gut-brain interaction have got chronic abdominal pain, pelvic pain, or pain after eating. So the collaboration between neurogastro, multidisciplinary services, and pain rehabilitation services in particular is really important. If a patient has got chronic pain, I can't simply push through that to help them expand their diet and re-nourish their bodies. I really do need your teams to help them understand chronic pain, to introduce medications that can help to reduce that pain that are non-opioid based typically. We really try to avoid opioids for lots of reasons that you're well aware of. And your teams have got physiotherapists, pelvic floor physios, dietitians, pain psychologists. They're all critical to helping patients recover from these chronic pain-based functional gut disorders.
One of the things about working with pain, and I'm also a psychiatrist and work in the functional disorder space, is how to explain it to patients in a way that isn't, it's all in your head.
Yeah.
How do you negotiate that in the functional gut disorders
Good question.
world?
The stigma is so real, isn't it? It's such a problem. And I could talk a lot about that. So I guess if we go back a little bit, that stigma is really deeply seated in a philosophy that underpins all of Western medicine. You know, as doctors, we are taught that a problem is either physical or psychiatric. You know, and those two shall never come together unless you work in functional medicine. Right? And that stigma, unfortunately, has meant that these diseases are widely believed to be somehow less valid or less real than a disease that we can see, like a broken leg or like an ulcer or things like Crohn's disease that we can see with our cameras. And yet we know that the symptoms that patients are living with are real. Every single symptom has a real physiological basis. Every symptom. Even if we haven't identified the molecular basis of that yet, that enables us to develop new treatments, every symptom is real. So in my clinic, I manage that by preempting that. So I actually will say that to patients very early on. Before I thoroughly reassess, I order any tests that they need. I make sure that we're not missing anything. You can have a structural disease and functional gut symptoms. It doesn't have to be one or the other. And then I talk to them about, okay, let's talk about what a functional gut disorder is and what it isn't. I'm sure that you've been told that this is somehow not real, that it's in your head. All that information is incorrect. We talk about the misinformation that's on the internet, and the internet is rife with misinformation about functional disorders. It's mostly incorrect. And then we talk about the very real ways that the nervous system, central and gut nervous system, the immune system, the microbiome, the very real physical, tangible ways that our emotions and our past and recent or current psychological stressors can cause physical symptoms in the body. And lots of analogies, like if we get a fright, our heart goes up, our heart rate goes up. You know, that is a functional symptom, not just from a fright, or blushing. So lots of really good examples that I use to help them understand that as well. And then I use a psychologist in our clinic to do a lot of really good validating education on the gut-brain connection.
That's really helpful. One of the things you mentioned in that was people coming with tests. And the last question I think we'll have time for is, sometimes we see people coming with unusual tests we don't understand, gut flora, gastric mapping, and I struggle to know what those mean. Are these kind of mainstream, ready for prime time? Are they things people are still figuring out? What does all that stuff mean in 30 seconds or less, probably?
Just that there are a lot of tests that are available to patients, more so in the US than here, but you know, patients will bring tests that they've ordered to look at their microbiome, their flora, salivary cortisol, all kinds of tests. In a nutshell, a lot of those are not validated. They don't necessarily mean that there's a problem. They need to be interpreted by a specialist. So I just always encourage people to bring those test results to us and thoroughly look through those and talk to them about what we do know, what we don't know, and ultimately focusing what we do know and what we can treat right now. And that's the most beneficial and most empowering thing we can do for them.
That sounds like one of the situations we would ring up you guys for help then.
Absolutely.
Okay.
Phone a friend.
Indeed. Well, look, thank you very much. Thank you very much for your time and for all those answers.
Thanks, Chris.